Hello everyone. I am Dr. Manasvi Gupta, consultant physician working in Hisar, Haryana, and we'll be discussing about early initiation with empagliflozin and linagliptin combination for optimal glycemic control in diabetic management. Evidence indicates that early intervention and achievement of glycemic control reduces the long-term risk of microvascular and macrovascular complication in diabetes. Patients most likely to have reduced CVD risk with intensive glycemic control were those with a shorter diabetic duration who had not yet developed atherosclerosis. For patients with HbA1c more than 1.5% above goal at diagnosis, ADA and EASD guidelines recommended first-line treatment with a dual combination and an SGLT2 inhibitor as the first post-metformin treatment in patients with established CVD, heart failure, or CKD. For patients requiring additional treatment for control of glycemia, similar consideration should guide the addition of a third agent, which may include DPP-4 inhibitor, if not on a GLP-1 or excluding sexagliptin in the setting of heart failure. The use of an SGLT2 inhibitor, GLP-1, or DPP-4 inhibitor may also be added alone or in combination in patients without ASCVD, heart failure, or CKD if there is a need to minimize hypoglycemia. AMPA and LINA combination with complementary mechanisms and pleiotropic benefits may be suitable option across a range of patients, including those with established ASCVD or high risk, established heart failure or CKD, due to the tolerability of the combination in addition to the potential benefits of empagliflozin on CV and renal outcomes, and no increased risk of heart failure with either agent. According to a study, early achievement of HbA1c goal that is less than 7% with AMPA and LINA could reach the target. Following advice can be given to patients while initiating this combination: maintaining proper hydration, perineal hygiene, adequate monitoring of body weight and blood pressure, blood glucose on routine basis, and informing treating physician in case of symptoms of blood glucose lowering. Follow the sick day rule in case feeling sick due to fever, infection, poor appetite, nausea, vomiting, or diarrhea. Further evaluation in case of burning or pain during urination required. According to recent ADA 2022 standard of care, first line therapy depends on comorbidities, patient centered treatment factors, and management needs, and generally includes metformin and comprehensive lifestyle modification. Treatment goal involves the control of glycemia and CV risk factor management and a patient-centered approach to care. The choice of pharmacological agents now considers the comorbidities in addition to the risk of hypoglycemia, impact on weight cost, potential for side effects, and patient preferences. Early glycemic controls leads to better outcomes, including a reduction in long-term microvascular and microvascular complications. For patients with inadequate glycemic control on metformin, addition of the single pill might be considered to help establish optimum glycemic control while reducing pill burden and avoiding clinical inertia in intensifying therapy. When metformin is not suitable and empagliflozin or linagliptin is being considered as an alternative first-line treatment, initial combination therapy may be considered to achieve target more quickly, particularly in patients with 1.5% higher than target HbA1c levels. It is reported that DPP-4 inhibitors improve beta cell mass and function via beta cell differentiation and proliferation, accompanied by decrease of oxidative stress and inflammatory cytokines. It is also reported that SGLT2 inhibitors improve beta cell mass and function via similar mechanism as DPP-4 inhibitors, although the mechanism of glucose lowering defect is totally different. In experimental study, combination of DPP-4 inhibitor and SGLT2 inhibitor exerts more beneficial effect on beta cell mass and function, especially in an early phase of diabetes rather than an advanced phase. So Empagliflozin is available as first-in-class treatment SGLT2 inhibitor and DPP-4 inhibitor combination group of drugs. At week 24, Empalina, with a dose of 25 by 5 mg, showed statistically significant HbA1c reduction. HbA1c decrements by Empalina combination has demonstrated almost 1.81% HbA1c reduction at HbA1c baseline, that is more than 8.5% at 24 weeks. Change in FPG reduction with Empalina was almost 32.2 at baseline FPG of 156.7 at week 24 and maintained at week 52 in metformin treated groups. Higher percentage of patients achieving HbA1c less than 7% were reported for both single pill combinations versus EMPA of 10 mg. Early achievement of goal, only FTC arm of Empalina could reach target HbA1c at 12 weeks compared to monotherapies. The combination offers a suitable component in strategy to achieve target HbA1c without hypoglycemia and weight gain. Additionally, it would reduce the daily pill burden in this population, potentially improving adherence to optimizing the benefits of the treatment of diabetes mellitus. Thank you.